Hi everyone, welcome to my short talk on DVT ultrasound. I'm one of your chiefs, Janessa Ledger. I am going to apologize that I'm a few months late on getting this out to you, as my chief duties have prevailed. And I also, believe it or not, being from Millinocket, am not entirely tech savvy, and therefore had no idea how to get the actual images from impacts to a PowerPoint, but my wonderful fellow chief Rachel Williams helped me figure it out. So thanks, Ray, and here it is. I wanted to focus on DVT ultrasound during my elective month because I feel like this is something we can do, and it's an exam that we can do fairly quickly, and it may be something that I need to know how to do in the future, as I may not have access to an ultrasound department as I do at Maine Medical Center. My hope is that this presentation will help you get a handle on the anatomy, what to look for, and then you can go out and practice on your own getting the images on patients. So first of all, why learn DVT ultrasound? Patients want to go home. They prefer not to wait hours in the ED for their imaging study if they can avoid it. Currently, even though we are not allowed to do these without getting a confirmatory study, there are some places where the ED physician is expected to know how to do these, and there may be some places where you don't have an ultrasound department at night, and so you're faced with the dilemma of, well, do I wait until the morning to have them get a scan, or can I just try to scan them now, see if I can see a DVT, and then they can have a confirmatory study in the morning and I won't delay any of their treatment or care. It's also fairly easy to do. You just have to know what you're looking for and how to obtain the images and practice it. The anatomy of the venous system and how the venous and arterial system in the leg relate to each other is important. Remember in medical school how they taught us navel being nerve, artery, vein, empty space, and then lymphatics in the groin, to remember kind of what order they come in. This is where it comes in handy. The other way to think of it as is by thinking that venous is closer to the penis if you have one. I won't say who told me this one, but I do find that it's helpful in remembering where the vein is in relation to the artery when you're starting your DVT ultrasound in this area, in the groin. Also, knowing the anatomy of the venous system is important, and knowing where the branch points are. The IVC splits into the common iliacs, and then the common iliacs split into the internal and external iliacs. The external iliac then, when it crosses into the leg, becomes the common femoral vein, and then the common femoral vein gives off the saphenous vein medially. And just distal to that, the common femoral vein bifurcates into the deep femoral and the femoral. The femoral used to be called the superficial femoral, but that was a misnomer because it was still a deep vein, so they renamed it just the femoral vein and a deep femoral vein. The femoral vein then becomes, behind the knee, the popliteal vein. That's going to be superficial to the popliteal artery, so that's important to know when you're doing the ultrasound behind the knee. And then the popliteal vein will then trifurcate, become the anterior tibial, posterior tibial, and the perineal veins. And that's also an important branch point that you're going to be looking for on ultrasound. Used to be thought that we could do 2-point compression to identify DVT in patients. So looking at the common femoral and the popliteal, making sure those compress, and then calling it a day. This idea was based mostly on a study that was done back in 2010. It was published in the Annals of Emergency Medicine, where they had 47 providers, most of which were residents, and a lot of them weren't emergency medicine residents. They were internal and family medicine. They had 144 patients and 40 DVTs in that population, and found that the ultrasounds were 100% sensitive that were performed by these providers. So people thought, well, we can easily teach people how to do this, and you can do the 2-point compression and compress the femoral vein, the popliteal vein, and if they both compress, then you're done. The problem with this is that most of these patients were ambulatory outpatients, and they were low risk, So most of the DVTs probably were propagating from a deep calf vein or down from a pelvic vein, and it didn't include higher risk patients, which is really what we often see in the ED. And there was another more recent large retrospective study looking at thousands of patients, 2,500 patients with suspected DVT, and 15% of them had a DVT, so 356 of them. 6% of those DVTs were isolated to the deep femoral or the femoral veins, which would have been missed by the two-point compression ultrasound. And some of those patients ended up having bad outcomes. So 6% miss rate is what you would miss if you did just the compression at the common femoral and the popliteal. So really not ideal. So people started doing more extended scan, looking at above and below the branch points that I identify here. So looking at the common femoral, where the saphenous comes off and distal to that, and then the deep femoral and the femoral veins after they've bifurcated from the common femoral, and making sure those compress, and then down into the behind the knee, compressing the popliteal vein, and then where you see the trifurcation, where you see 3 vessels, making sure all 3 of those also compress. So this is a little more comprehensive and will catch more of the DVTs, especially the ones that are in the femoral vein and the deep femoral vein, because there are patients who are higher risk who will have isolated veins in the deep femoral or the femoral that we wouldn't be able to see if we were just compressing up in the common femoral and in the popliteal. Patient positioning is also something that you're going to want to think about. Often our patients are laying supine on a stretcher. They're almost always in the hallway. Making sure that you bring them somewhere where they can have a little bit of privacy, or into a room. Making sure they're in a Johnny, and you can expose the groin area so that you can place your probe where you need to, because you do have to go fairly high up in the groin, higher than you think sometimes. It may help to have the leg externally rotated to avoid kind of the large crease in the groin, although some people will have that crease no matter what. And then in the popliteal space, sometimes I'll have the patient just bend their leg up with the foot on the bed, or you can see if they can externally rotate, and you can place the probe behind their knee that way. And often I'll have another hand on top of the knee itself to give yourself a little bit of pressure for when you're compressing the vein. This is an example of what you're going to see when you start up in the groin. You're going to look for the common femoral vein and artery. They're going to be next to each other. The artery is going to be lateral to the vein, and then you're going to see the greater saphenous coming off, and you're going to look for this kind of image that looks a little bit like Mickey Mouse ears. So this is an example starting in the groin, looking and seeing the femoral vein here with the greater saphenous coming off, and the femoral artery here. This is actually a lymph node up here. And you can see that compresses quite well. And you can imagine how this looks a little bit like Mickey Mouse ears. This is another example with the femoral vein here, femoral artery here. The femoral vein compresses nicely. You're going to make sure you go above that and below that. Here you can see the Mickey Mouse ears again. And make sure that the vein compresses both above and below that. You're then going to scan a little more distal, when you start to see that bifurcate, and you'll see that'll be the deep femoral and the femoral, and you want to also make sure those compress distally. Sometimes that part can be a little bit trickier to try to find where it bifurcates. I think we're just at the beginning of it there. And then you're going to scan distally behind the knee, and this is where you're going to look for the popliteal vein, which is going to be on top of the popliteal artery, the pop on top. So you can see here the vein is nice and compressible. And then you're going to scan down a little more distal and find the 3 vessels and make sure all of those compress. This is an example of actually a positive scan. So here is the popliteal vein, here's the popliteal artery, pop on top of the vein, and I'm pushing, and that is no compression of that popliteal vein there. You can see actually the artery seems to compress more than the vein does. And then you're also going to distally scan to see if those three vessels compress. And in this patient, they did not. And he went for a formal ultrasound, which identified a clot in the TP trunk. You can also kind of see how that is a little bit, it's not as dark as what you would imagine the vein should look like. So that's, I think, a clot right there. So in summary, keeping in mind the anatomy and especially the branch points where you're going to need to identify on ultrasound. And of course, practice makes perfect. The only way you're going to get better at these is by doing them. I just barely started to feel a little more comfortable at the end of my ultrasound elective, but still feel like I could use a lot more practice. If you have a patient who you're concerned for DVT and you think you have time to scan them before they go over to have a scan with the ultrasound department, I would definitely do it. Take advantage of that opportunity, and because you may not be spoiled like we are at Maine Med in the future and be able to have a confirmatory study at your fingertips. So that is all. Thank you.